Electrophysiology. We're going to go through, it's all about how the heart contracts in sequence. We are familiar, or should be, after being in 201, to know that the brain sends nervous signal down the spinal cord, out the spinal cord, and then it moves, that little axon comes out, so you have that little bulbous axon terminal, synaptic bouton, synaptic terminal, whatever, there's like a multitude of names for that. Right, hovers over, remember it's like you got a neuromuscular junction, say to our bicep, and then it's going to release acetylcholine, gets onto the sarcolemma, does its sort of excitation contraction thing, and what do you know, our bicep contracts and it gets twitched up and down. There you go. And so every time our heart beats, we do not want to have to go through that. Our brain, okay, beat now, you know, so we want our heart to be able to just beat on its own. We have nerve connections to the heart that help us to make it go faster or slower, but we can cut out a heart just easily and just let it hang out and sit and just hang out and beat for a week. There's, in the lab that I used to work at, we talked about this setup called the Langendorf setup, that you could cut out little rat hearts and you can put it up. Actually, I have a video, so I'll show you the video while we're here at it. So this here is a rat heart that was just, and it's just beating. It's just out, sitting on a dissection tray, beating on its own. Has no nerves going to it. They're just showing you how you cut open. This is the aorta they're trying to expose the aorta so that we can move it onto, so you slide the aorta up to this little system and it's just beating. There's no nerves going to it, no electrical activation. Later, if you want to get fancy, you can put electrical activation and pace it. So maybe you want to pace it slower, make it go faster, you want to modify it. So these are some lungs. They're going to just cut off the lungs, so we just have the heart available. But the point that I'm making is you don't need nerves to get the heart to go. The heart will make itself go on its own. And you can put it on one of these setups, and as long as you get your saline solution, maybe go steal that little oxygen bubbler that's in your fish tank, put that in the saline solution, throw a little glucose in there. We can have that baby in the corner here, and it could be beating for a month, at least a week. Couple weeks, depends on how good you treat your heart. So it's just happy as long as it's getting oxygen and glucose, and it's you put it through the aorta, because if you clamp it, it will send the oxygen and the glucose through the coronary arteries. As you know, they come branches off there. So that's how it is. So this is the heart just sort of beating. That they could do, and I did want to fast forward so you can see what the whole setup looks like when you sit it. So you can see it's a little bit not as easy to put together. This one's kind of fancy because you can change and add different elements that you're going to add into there. You want to modify the heart rate. But you basically have this tiny little heart there that's just going to beat until you go. So we'll go back to the lecture. So electrophysiology is the electric pathway through the heart activates different parts of the heart at certain times so that the contraction can be in a coordinated manner so it can move the blood effectively. So what we say, electrocardiogram is known as the ECG or EKG, either way. It's called electrocardiogram. I went to graduate school in Canada, so we used ECG because cardio starts with C. The conducting system that you need to know about is the sinoatrial node. I wrote these hyphenated. They are most frequently written without the hyphen or the capital as one long word. I put it in there because I wanted to emphasize its geographic location. So you're going to need to know these elements. We're going to go over these several times. So sinoatrial node is going to be the first portion that's going to be activated. It then activates across the atria, which then goes the second red dot, which will be the atrioventricular node, meaning it's between the atria and the ventricles. Then we have this bundle of His, which is the little line here. Then it goes to the bundle branches, and then ultimately the Purkinje fibers. The Purkinje fibers are the ones that's going to actually activate the contractile cells of the heart themselves. So the rest of these guys are really more like wires, you know, just wires in the wall kind of thing, where it's really not activating anything adjacent to it. It's these Purkinjes that are going to come back around and actually activate the contractile elements. So the conduction pathway we can see here, sinoatrial node. The sinoatrial node normally sits in the back of the right atrium, kind of right near where the superior vena cava opens up, just below inside from that. You're not going to grab the hearts that we dissected on Monday and see it. So it's not something that's a visual. It is an electrically distinct region, meaning at the electrical level, on the cell membrane level, there are some very keen differences that allow it to be more electrically active than just the workhorse contractile cells around it. So we're going to talk about that. This is where we're going to flash back over to action potential. So any of you guys that thought that you were safe after you did neurophysiology in 201, it's back. So we're going to work on that again, hopefully do a recap that gets everyone back on the same playing field, even though you tried to purge it from your brain, but it's back. So we can see sinoatrial node is going to be tucked up here. We see fibers are running through, it's not really fibers, they're just more electrically sensitive cells. Then we have the atrioventricular node at the bottom of the right atrium, but at the top of the ventricles, we have our bundle of His, which is at the top narrow part of the interventricular septum. We have the two bundle branches. We have a left bundle branch serving the left side of the heart and the right bundle branch serving the right side of the heart. It comes down to the bottom, and as it comes up, even along the septum and the free wall are these many, many Purkinje fibers that will be activating the contractile cells so that they all can then in concert with each other. Because you don't want, say, this bottom part to contract and then this top part, because it's going to can't develop force to then develop. Very, very important of the timing of when these muscles ultimately do contract. And then we can see this other schematic here of some of the electrically active cells throughout there. So as we go through, we're going to talk about this. Our hearts are not straight up and down, they're going to be tipped. So this is an important component of really thinking of these electrical pathways. We talked about up here being the right atrium where the sinoatrial node is. Comes down the septum, hits the bottom, Purkinje fibers coming back up and around. So instead of drawing the heart like this, we're going to draw it so it's tilted. So this is going to be our left atrium, our right atrium, left ventricle, right ventricle, because my drawings are so bad, they have to be labeled. So in the right atrium, kind of at this upper back wall, we're going to have the sinoatrial node. Sinoatrial node is known as the pacemaker of the heart. So we have that coming up. I have a slide just that says that. It's known as this pacemaker of the heart. It is going to depolarize, which means it's going to become activated. This is a self-depolarizing region. This is the key to why we can cut a heart out of a body and let it sit there on the dissection tray and have it just beat around. Sinoatrial is known as a pacemaker. If you recall, we're going to do a little step back in time and we're going to talk about a nerve physiology. If you recall an action potential where you had the nerve here at minus 70 millivolts. You guys remember that? Resting membrane potential? Okay, so the nerve is really happy. Do you guys remember why a nerve is at rest and it's actually in balance at a negative resting membrane potential? What makes it so negative inside compared to the outside? The outside's very positive, and that is because of what? Let's see what else. Here's our cell, and the outside is very positive. I heard it. Thank you. So it's very positive because of sodium. There is some sodium inside. There's also, the inside has organelles which are negative, really negative. So they add to the charge as well. So if the outside has loads of sodium, what does the inside, which ion? Potassium. Excellent. So we have loads of potassium inside. So these are concentration gradients. And actually there's really way more sodium than there is potassium. But you can see now that if a sodium gate were to open, and when there's gates, voltage gates or chemically gated gates, they're dedicated only to that ion. So once a gate opens, you're not going to have a potassium going through a sodium gate. So if we were to open a sodium gate, which way is sodium going to go? It's going to rush into the cell. Exactly. So if we're at resting membrane potential, normally what happens in a nerve, here's our little nerve, here's our axon, here's our synaptic terminal. We're really focusing on what's going on at the axon. This is what our drawing is going to be about. How do we get it to start? Well, usually a nerve has a nerve before it that drops some neurotransmitter that actually opens sodium channels, so the cell body of a nerve got really, really positive, which triggered, so if we're measuring the first part of the axon, it was sitting here, minding its own business, sitting at nice, normal, resting membrane potential, and then its neighboring area here got really, really positive. So it's sort of starting to get a little more positive because it's sort of leaking over here until it hits what you guys remember as the threshold voltage. Remember that? And so it's around -55. If you depend on whichever book you look at, it could be 50, it could be 60, it varies around there, but around there, and this will be our threshold. And when the threshold is reached, I'll draw it. That's when the voltage gated channels here will open. So let's do this. We open it. Our sodium is now going to rush in. When sodium rushes into the cell, we depolarize and it becomes more and more positive, which means here we are, it becomes less negative. So we're at -70, 55, we hit 0, we peak out at +30 millivolts at the peak. Are we all on board here? Okay, good. Let me erase this, get this out of the way. So this is, again, just sticking with nerves at this point. We peak out at +30. At 0, we start, a lot of our sodium gates start to close. I like to say if you're driving a car and you put your brake on, you don't stop right then. You put your brake on, you got a few feet that you're going before you stop. So this is the brake going on at +30, it stopped. So these gates here are completely closed, no more sodium's coming in, not going to get any more positive, and in fact, not only is it closed, but it's locked. So now the cell is in kind of a pickle. It loves being at -70. Now it's kind of not happy. It's in this +30. It's uncomfortable. So it wants to do something that will allow for it to return back to negative territory where it's a lot more stable. What is it going to do that's going to help it go back down to negative territory? Yep, it's going to repolarize. So, and actually we should use some terminology. Thank you for saying that. So this is known as that is depolarization. That's what I wrote coming up there. Let me take this little video thing and kick it to the right a teeny bit. There we go. Can't really see it, but I'll try to remember to take a picture so we can insert it. Okay. Hit the peak, these guys close, and then at +30, so not only at +30 did we shut down the sodium channels, but at +30, we are opening the potassium channels. Potassium leaves the cell, now we have something positive leaving the cell, and we're able to go back down. Then the cell says, whew, I'm so happy to be back in negative territory, but I got my potassium out, I got my sodium in, so you did the whole sodium-potassium exchange pump to rebalance things. Everything kind of works out better, so you have that little overshoot, and you're back at your resting membrane potential. Okay, that was your neurophysiology recap. Okay, hopefully it wasn't as painful the first time you did it. And then we're closed and everything rebalanced. The sinoatrial node. we have this is self-depolarizing. Remember, this whole thing came because another nerve told a nerve, hey, here's some chemicals, open up taps. So we depolarized it. In the heart, this area of the cell, so we'll make another cell here, this cardiac cell here, we also have loads of sodium out, here's in the heart, and we have potassium in, little potassium out there, little sodium in. But what these pacemaker regions have, let me grab my purple, because the atrioventricular node also has it as well, is sodium doggy doors. Now maybe that's not the most, my friend that's a neurophysiologist would probably cry if he heard me say that. So there are these little leaky, I like to call them doggy doors, meaning they're really not regulated very well, but sodium can sort of sneak its way in through here. So over time, we can see that if we were to draw the graph here, so if it's at minus 70, and really the heart's at 80 or 90, but just to be consistent, not to throw too many monkey wrenches in our thought process, instead of just staying at resting membrane potential and waiting for something to happen, these self-depolarizing cells, literally, so if we have 50, if we stick with the numbers here, if this is going to be our threshold voltage, then what happens is with sodium sneaking through these doggy doors, we can see that it's just rising, rising, rising until it hits its own threshold. It didn't need a nerve to do that. Does that make sense? You guys with me on that? So it is self-depolarizing. The sinoatrial node will bring itself to here, and then it does its action potential. Once it does it, it becomes positive in here, and like then any other cell or even down an axon of a nerve, it's going to make the area around it positive. And you can see it becoming positive, and so you end up with these vectors. Physics term are vectors, which means these electrical paths sort of conducting in these directions. It has to do with magnitude, how much electricity, and the direction. This is what's going on. You have one area that's self-depolarizing because it's leaky sodium. Everything else, the cells around it, aren't leaky. It's just waiting for, say, the sinoatrial node cell to become really positive, which then triggers their channels to just be open, and it makes this one positive, and so on. So everybody else is sort of like just or a domino set. One gets positive, makes a neighbor, positive, makes a neighbor. But you got to start somewhere, and the starter is the sinoatrial node. But the atrioventricular node is known as the backup pacemaker, because if the sinoatrial node doesn't do its job and depolarize, the heart's just going to be sitting there waiting. I need a beat. I need a beat. And then the atrioventricular node will then come to the rescue and initiate a beat. Let's think about that. If the sinoatrial node does not stimulate the heart, and it has to wait for the backup pacemaker, being the atrioventricular node, will or faster. Slower, exactly. Because if we were talking about this red line being the sinoatrial node being leaky, you know, letting the doggy door, the atrioventricular node is also leaky, but its leak is a little less. So you have a little more of a time gap before it's going to fire. So in a normal situation, sinoatrial node fires, sends a signal, and stimulates the atrioventricular node before it has a chance to stimulate itself, if you will. But if there's something that goes wrong here, it will stimulate itself so it can send the signal down to the ventricles. Because the atria, if they don't contract, we're not dead. If the ventricles, they don't contract, we're dead. So it's back up here, so the signal's still going to get down to the ventricles to do its thing. But it just is a slower time course as far as the lead goes. On here, the sinoatrial node, this is where the vector thing comes in. The net vector from the sinoatrial node across the atria is that. Does that make sense? If we were to add up all these little arrows, you sum them together, the net movement of charge is across the atria in that lateral fashion. The other thing I forgot to tell you earlier is when we follow our sinoatrial node, atrioventricular node, sort of the bundle of His and all the other things we're about to get to, we have a very specific path from the atrioventricular node down into the ventricles only through this area. That means a cell over here in the atria will not activate a cell over there. We don't want the pathway to come over this way. That can't happen, or else we're going to have all kinds of weird things. And actually, it's quite cool when it happens. Well, not for the person. It is for the electrophysiologist or the cardiologist if you're looking at it. Really interesting, fun, crazy electrocardiogram, like Parkinson syndrome, where it's actually reroutes through itself, and it's quite fun to see. Not for the person, obviously. So the heart has this, what we call an isoelectric band, meaning iso, same, it will not let it go through except for only this area. Okay. So that having said, we activate the atria get its signal, the atrioventricular node is now going to get its signal, and then it moves it on down straight to this. So we have the atrioventricular node activated. We're going to bring it here to the bundle of His, and then it moves down. So the bundle of His at the top of the interventricular septum, if you guys remember, is really narrow. And then it gets really, really thick. So it has to branch off. So we have our right bundle branch and we have our left bundle branch. And it hits the bottom of to the apex of the heart, and then it comes back up and around. So now it's coming back the other way, and here we are. So we'll do this in a different color. We'll do these guys in blue. Coming back up this other way. This color coding's coming into play in a little while. Guys with me on this? And that's the sequence that the heart gets activated. Effective, what we're trying to get from the heart is atria, here's a signal to contract. It's like this electrical stuff is like pushing the doorbell. It's the electrical signal, and then you expect the door to open. That's the mechanical event. So atria gets the signal, the depolarizing signal, that's what this is, and then after it, it will contract, push blood down. Ventricles get its depolarizing signal. After it gets a signal, the walls will come in and squeeze and shoot blood out. So you have the electrical followed by the mechanical or physical event. If you have a practical exam, you should expect to see probably a drawing of the heart, maybe not as bad as this one, I might show one of these, and have those little blobs on there and have you label it, or I'm pointing to it. Hey, what's number 1? What's number 2? But I also want to remind you, I'm not big on abbreviations. So that would be like, you get half a point off for spelling mistake. So you would write atrioventricular node, and you would write out sinoatrial node. And then for the rest of your life, everyone else will know it as the SA node and AV node, because that really is what people talk shorthand. But at some point in your life, and that would be now, you have to know what the whole thing actually is. So then you can go back to your abbreviations. My thing too is to explain everything to you, get a picture in your head, and then I'm back to my really boring wordy slide. So we'll go through, because this is what you're going to be taking home, and you're going to see this later, but hopefully now it just looks less word jumbly. So when we say sinoatrial node is in the superior posterior region, so it's in the right atrium, tucked up, kind of where that superior vena cava comes in. It's known as the pacemaker because it's the one that's going to depolarize first and set the pace of the heart. So it will be the main initiator of a new beat. It does it because the cell membrane in this area is more permeable to sodium. That's the doggy door story, where it's just begin, and so it will allow itself to reach its threshold. And that way, the action of the sinoatrial node and these vectors going across the atria is what's going to tell the atrial muscle to contract. So that's the initiates atrial contraction. And I put initiates in italics because it isn't atrial contraction, it's the signal for contraction to happen, which happens in the moment afterwards. So timing-wise, electrical signal first, and mechanical event or contraction second. The atrioventricular node here is the lower portion, inferior, bottom, medial, towards the top of the septum. It's the backup pacemaker, so it also is a self-depolarizing region. It is going to not only be a backup pacemaker, but if its backup pacemaker job it's not being asked that of it, it is a relay station, meaning it brings in this impulse and it's going to pass it on down to the ventricles, but before it does it, it's going to hang on to it for a minute. It's just going to be like, you know what, I got it, let's hang on. Okay, now ventricles, you can have a slight delay so that the atria have time to contract and push blood down before the ventricles do their thing. So it kind of allows for the delay. So this idea here is cell membrane is more permeable to sodium. That means than the normal contractile cells, but it's still less permeable than this SA node, which means it's not as leaky. So that's why it's the backup. It's permeable, but it's going to be slower to reach self-threshold, if you will. So that's the explanation of that. So the conduction sequence, as we see, is it starts here at the sinoatrial node. They kind of drew it a little high on this one. Kind of goes across the atria. So we have the atria, depolarized in purple. We now hit the AV node, atrioventricular node there. That second portion of the picture, we're going to send it down to the ventricles. So we go to the atrioventricular node. Again, bundle of His. It's here at the top. The left and right bundle branches are these two coming down the thick part of the interventricular septum. Purkinje fibers are what's actually going to the contractile muscle cells themselves. So that is important that you know the names of these things. And then now, as we put leads on and we're going to detect it, we're going to start drawing like electrocardiogram waves, knowing how these waves are made, what the electrodes are picking up that translates into these waves is important. So this is where I'm probably more picky than the average bear because I think it's very important and will be important later for you. You'll appreciate, it's one of those things, you'll appreciate this later. I have students learn what the electrodes are measuring at a very fundamental level so you understand what the signals are. Not just this wave is this letter and it means this. You're gonna have to know that, and we'll get to that. But I want you to know is how it got to that point. So there's a little basic science that we got going on here in between that are some test questions on it, not a huge amount. The majority is gonna be on the actual application of it, but I definitely think it's very important that you know this. The electrodes are placed there's two different types of electrode placements. There is Einthoven's triangle, which really views your body as, let's see, we'll grab this. We have a heart. The heart's here. It's tipped over. So if you imagine your two shoulders and your left hip making a nice triangle that fits the position of the heart quite well. We have a fourth electrode on the right hip that acts as a ground or reference point, but it's not, it's used in some measurements, but for our purposes, we're just going to deal with the triangle over here. The chest leads are placed on the front of the chest, and it views the heart inward to the body. You do need to know, are the three Einthoven triangle leads, and we will go through those now. Before we hit the leads, we need to know, what are these electrodes detecting? If you're going to put on, let's see, an electrode on a person, electrodes always have to come in pairs. So this would be considered a lead, even though one of them's a lead. In the Einthoven's triangle universe, this is not a very sticky shirt, but in the Einthoven's triangle universe, a pair is considered a lead. So this set, so you have basically one side's negative, one side is positive. So that's why I have it drawn this way. So we want to keep that in mind, because if we do negative over here, and we do positive here, stickies are running out. You can see how our pathway and our vectors, it's going to be really important to know, are we running a vector to this, or are we running a vector away from it? So these are things we're going to be doing together. So what do these electrodes just detect at a very basic science level? They detect direction and magnitude. Magnitude means how big it is. So if you have a lot of heart mass, which we do in the ventricles, the signal is going to be huge. The atria, thin walls, really thin, the signal will be really small. So any waveform that we pick up from the atria is going to be about this big compared to like this big for the ventricles. So that gives you a sense of size. Even on a person, you have a kid, their heart is physically smaller, their electrocardiogram reading will be smaller. You have to turn on the gain that actually magnifies it or amplifies it compared to a very big person. So the physical mass of the heart tells you how much electricity basically it's generating. And it's going to tell you, are you depolarizing? Oh, here's Einthoven. Are you depolarizing? You have this depolarizing rate, or are you going to repolarize? That tells us if you're depolarizing or repolarizing, tells us what's going on in the cell. Because remember, the cell is all about, if it's depolarizing, you have pluses coming in, and then you have another cell over here, and if it's pluses, so I'm going to just put this arrow, because you have this positive wave essentially going over. You guys good with that? So if we have this electrode here, and you can't have a positive without a negative on the other side, basically. There's always going to be. So if you have a positive wave going towards a positive electrode, I'll give you the end. Gosh, I'm jumping ahead of myself. If you have a positive wave heading towards a positive electrode, the chart recorder that you're going to measure, so if this is our little monitor that we have, a little TV monitor, and we can see someone's electrocardiogram, if you have positive going towards a positive electrode, you're going to see it as an upward dip. If you happen to put the electrodes on backwards, you'll see it as a downward dip. So a positive wave towards a negative electrode will be down. Or if we repolarize, where the cell gets to be negative again back inside and the cell's back to being happy towards a positive, it's going to go down. That's just basic measurements. But I got ahead of myself on my slides. So we'll go back. So the electrodes detect how big the impulse is electrically and where it's going, the direction. And if you have a depolarizing, like we're talking about through the heart, we depolarize here and we're depolarizing down, and then we depolarize this way, it just tells you, are you going towards, one here, are you going towards a positive electrode? You're going to see it as up. If you're coming back away, you're going to see it as a down. That's how the waves are made that we're going to be learning about. Where did this come from? Einthoven, of course. So Einthoven's triangle came from William Einthoven, and this is him. So he's from the University of Leiden in the Netherlands. The Netherlands is a hotspot for cardiovascular physiology. My master's degree I took under Heinrich ter Kurs. He's a Dutch cardiophysiologist. And then I did my PhD with a different lab. But in 1887, was the first recording made. It was actually done in St. Mary's Hospital up in London. He then presented it to the British Medical Society, and ultimately in 1924 he won the Nobel Prize for it. And it was for the discovery of the mechanism of the electrocardiogram. And in fact, the first person that had the electrocardiogram made had just died, just a little bit before he received the Nobel Prize on that. So this is actually the first electrocardiogram machine. Guy sitting there, his hands and his feet in salt water. It's really what it is, so they can measure electrical current. And so you can see wires coming from the tubs, and it was a way to amplify these electrical signals. And some of the electrical signals they have in the British Medical Society, and I think it's in the museum there, showed that. So it was the original way of really determining what's going on in the heart, and it was through World War I that a lot of this really amplified. You can see it received the Nobel Prize after that time, and so it really refined itself. So cardiovascular physiology really revolutionized in this century, this previous century actually. So don't worry, Einthoven's not on your test outside of his leads. The electrode placements that we're going to talk about, you either have your chest leads, which are the V's, or your four corners here. And so we're going to focus on the four corner one. And we'll, if we have time, we'll come back to the chest leads. So the heart, again, is tipped. So I wanted to emphasize that with this picture of the heart in this image. And then this shows you the leads if you're just dealing with the chest leads. And in fact, lead 5 and 6 really are right by where the heart is, the apex of the heart is. And 1 and 2, should be a little bit higher, are really about seeing the heart from the top. And these are important, even though we're not doing these in class, looking at these chest leads. So if you were to look at an electrocardiogram and see a 12-lead EKG sitting there and you're thinking they all look bad, they look, the waves that we're about to go through look different depending on where you are on the playing field of the thorax, really. So, and so this is something that if we have time, we'll come back to, because I think it helps to solidify some of this patterning. So this is what I jumped ahead to do. What we measure, when we measure a positive deflection, that means the wave going up, is, in this case, if we have a resting cell, it's negative on the inside. As a depolarizing wave comes through, it's the cell being positive. And it's positive moving towards, and this here is a positive electrode. So if you have a depolarizing wave moving towards a positive electrode, the signal will go up. We haven't gotten to it, but one of the leads in Einthoven is your right shoulder and your left hip. The positive beam is always going to be on the left side. So our positive is sort of a sensor picking up positive movement, if that's better contextually. So here I have this, switch hands, heart tipped. See the interventricular septum coming down. So the depolarizing impulse that's coming down, that would be the orange line here. The depolarizing impulse that comes down, if it's in parallel to the two electrodes that's measuring it, sort of thinking it like a tunnel. If it's in parallel, it will give you the biggest signal. If the heart is tipped a little bit away, you'll still see it. It's still going from the right to the left, but it's not going to be as big of a signal. You're kind of like not as in tune with it, if you want to think of it. And in fact, if you're exactly perpendicular, you won't see the signal at all as it goes down the interventricular septum. So you can see the signal is going to get bigger and bigger and bigger if we're talking about only, I need more hands, only going down the septum. Got it. So no signal to maximum signal. So the idea here, and that's because if we have a depolarizing impulse going down, 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 it's going toward the positive electrode, going towards, therefore you see it going up, 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 up. The drawing and the tracing goes up. When it hits the bottom of the ventricle, it's going to hit the bottom, and now it's coming back away. Then we'll see the tracing go down, and that's how you would get a negative deflection, depolarizing away. So these slides are probably not the best. I was not conceptually good at coming up with that, but I want you to have the concept And there will be probably 2 test questions on this, where it says something to the effect of, if it's a depolarizing is becoming positive, depolarizing wave coming towards a positive electrode, it could be here too, coming towards a positive electrode like we see here, you're going to get a positive deflection. If it's repolarizing, meaning the cell's getting negative again, then it's going to be negative. Or a depolarizing away. That makes sense. So they're kind of, so it's a lot more wordy. I think conceptually you can get an image in your mind. It's just sort of the words kind of overlap it and make it more confusing. But if you understand a positive wave to a positive electrode makes it a positive deflection on your chart. And then depolarizing away from it is going to make a negative deflection. It'll make more sense as we then actually see it in the heart, I hope. So Einthoven's triangle, we have our electrodes here, and ultimately we are thinking of the body with the negative is going to be on this right side and the left side is going to be positive. Lead 1 in Einthoven's looks at the 2 from the shoulder to shoulder. This is lead 1. This is lead 1. This pair of electrodes is considered a lead. This is lead 2, and this is lead 3. So I have a question for you. If the heart sits here, again, tipped over like it is, deflection, a signal that you're going to get for depolarization down the interventricular septum, would it be bigger in lead 1 or lead 2? And why would it be bigger in lead 2? Because it's the most parallel. It is more parallel than it would be in lead 1, but lead 1, it's still going to a positive side. So you're still going to be positive. It's just not going to be as big as if it was here. So I definitely, you need to know that, because that is really the fundamental of understanding why somebody's electrocardiogram might actually be different. What if they have like right or electrical signal coming off the wrong side? It actually could throw your electrocardiogram off. You might have a huge lead 3 and a really non-existent lead 1, and it seems weird. So it helps explain why some things are how they are. Okay, so now you have all the basic elements. We're going to go through the waves. So these waves represent one heartbeat. I'm going to draw the electrocardiogram. What initiates the heartbeat? What's the pacemaker? Sinoatrial node. It is going to depolarize across the atria. So here are our electrodes. Positive is going to be on this side. We'll not necessarily make a distinction of lead 1 or 2. We're just going to go, if it's going this side of the board, it's going to be positive. If it's coming away, it's going to be negative. Depolarization of the atria would result in a positive or negative wave. Positive, because it's kind of the net vector is heading that way towards this positive. So we're going to see it as, the black is going to be the baseline, and then we see this positive look. Good with that? That's this. Okay. Then once the atria get depolarized, what's happening? What happens next? Atrioventricular node gets the signal, but kind of hangs on to it. But if it's hanging on to it, it's not moving it. And if it's not moving, the electrodes can't see it. It doesn't pick it up. So we have this weird flat line. That flat line is really the atrioventricular node kind of hanging on to it. And it starts to send it over to this bundle of His initially. Now, from the bundle of His, we're sending it right on down this interventricular septum. Okay? Is that going to be positive or negative? We're heading on down. Positive. We're heading on down. It's going towards the positive side of our body. So we see it as a positive deflection. Now, what kind of warps people out is that I drew this here, so it's like physically going down, but then I'm drawing this in the opposite direction. So don't let that go. You're just thinking, all you're seeing is it's closer, closer, closer to a positive electrode. That's all it is. It's coming closer and closer, so it's continuing to be more and more. Think about it as almost like as a train coming to your ear. It's louder, 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 louder as it's coming down to the tunnel towards you. So it's getting more and more and more positive. It hits the bottom of the heart. So this is where an electrophysiologist is going to cringe, because this, what I'm about to tell you, is not 100% physiologically accurate. It is conceptually correct for how you want to move forward and understand this, but there are many other physiological components that are underlying that I'm making gross generalizations on. Doesn't affect anything that you guys are going to do, but if an electrophysiologist were to hear this, they would be cringing at some of these generalizations that I'm making. When we hit the bottom, we're going to now, and this is the sort of ricochet, if you, for sort of lack of a better term, but see how it's going down, now it's coming back up, and is it going toward the positive or away from the positive? Away. So because it's going to go away, are we going to expect a more positive, or are we going to expect a negative deflection? Negative. So this is coming back, and then here we go, we're coming down, and then we reset. Okay? So this whole orange, blue, and the green, I didn't really write the green, the orange, blue is all about the ventricles. And then the ventricles got its activation, and then we're kind of just flatlined again. And then we do this little thing at the end where I'm running out of colors, just do the brown, where we do the last wave in brown. And all that last wave is the ventricle, once it depolarized, is going to repolarize. Now, in a true ideal fashion, if we were in a perfect cell setting, the pattern of depolarization would just be done in reverse to repolarize, but that's not the case in the actual heart. So it again is that stuff that I said, there's all these underlying elements. Just know the whole resetting and relaxation components of the heart, getting the potassium, the sodium to rebalance after the depolarization. It's doing it at different paces, at different areas. So the sum of that activity is just this weird little mound. So just know it for that. Yes?
At the height of that signal, the highest point, that basically when it's in the apex of the heart before we turn around.
Yes. That's where the electrophysiologist is like, all right. But yes, for the purposes here, that's really what you want to think of, going down the septum, and then it's now coming back away. And from a very fundamental level, it is. You're either going towards a positive electrode or you're going away from it. And that's really where the signals are coming from, or the signals are about. So let's recap this, and let's put names to these things. This first wave here that we got in here is known as the P wave. The P wave represents the sinoatrial node self-depolarizing, and then that impulse is now traveling across the atria. And it is this motion across the atria that lead is picking up. It sees this movement of positive charges. Okay. And it's depolarizing the contractile cell. So the signal is going out. This next little segment here is known as the PR segment or PR interval, and it's actually timed from the start of over here. So I don't have a test question on PR interval, but I do want you to know the sequence of what's happening. So the PR interval, or this PR segment, is really because it's the atrioventricular node getting the signal in, hanging on to it before it relays it back down to the ventricles, which would be the bundle of His, is the next spot. It is during this time, if we had the P wave was the signal to tell the atrial cells to contract. Well, their actual contracting is happening here. So I want you to realize, yeah, it's a flat line, but that means electrically nothing's happening because mechanically something's happening. So like I said, the doorbell is the buzz, and so now the door is actually doing the mechanical movement. This is only picking up charges moving through the box. So if we want to think of this, I'm going to grab this here, we can actually say here, atrial contraction. So that's a mechanical event. Then we have here, this whole area that we're going to talk about is the QRS complex. So we'll name this here. This corner is Q. Even if it's not a corner, maybe it's drawn as a jagged down and up, then that would be a Q. It's an actual wave there. Even if it's not an actual wave, it is considered to be Q. That is because the top is always going to be R, the peak. And this guy here is S. Sometimes it's not a jagged down. Sometimes it just comes as a corner and goes over. Well, then that'll be S. Just know the peak is always R, and Q and S is always going to be on the other side of it. So collectively, all of them together is known as the QRS X complex. Some books call it the QRS interval. We'll all refer to it as the QRS complex. So where we have Q to R, bundle of His going down the septum, and then the other part is it coming back. But I'm not going to have you break it down. Just in general, QRS together is going to be ventricular depolarization. And then I should write that here. The P is going to be atrial depolarization. Okay. Then after, so do you guys remember, after the ventricle gets its signal, what is it going to do? Exactly. It's now going to contract, and its contraction phase is going to be right here where the flat part is. So this here is actually where ventricular contraction occurs. So just to jump ahead, this next wave is known as T. So the ST segment, which is here, is where the ventricles are contracting and squeezing blood out. If somebody is having a heart attack, a myocardial infarction, meaning their heart was already compromised and how much oxygen was supplying the heart muscle, and so therefore, when we're asking the heart muscle at a time to work, it's going to be like shouting its pain and shouting its agony to you. And it's shouting its agony, although normally the contraction phase would be isoelectric and that you're not going to see an electrical change. In a person currently having a heart attack, you will see a change. And the first change that happens is this baseline where this line is rises up. And it's known as ST elevation. And so that is your indication that someone is having a heart attack, because we know we're in the ventricular action time, and that's what we're going to see there. So that's just something to look for. And then the T wave collectively is just ventricular repolarization. And that's when the potassium's getting put back into the cell and the sodium's getting kicked back out and all the rebalancing is taking place. Okay, are we all feeling good about this? Are we feeling overloaded? There's a lot, so we're going to see, when we come back in the next class period, we'll be going through the cardiac cycle. We're going to go through the PQRST and the timing of what's going on in the heart. But we'll continue with this. We'll keep going here. We will do a quick recap. Okay, on our quick recap, let's do it this way. So maybe I'll do it backwards. If we have our P wave, who can tell me what's happening in the P wave in the heart? Atrial depolarization. So if we were to draw it here, tilted. Ooh, that's a really hideous heart. Okay, so our P wave that we have here, we know it's atrial depolarization, which means here's the atria, and now we've just depolarized over there because we have this side of the body's positive and this side of the body's basically negative. Good there? So we have a positive wave and then it's over with. Okay? Then what happens next? Before ventricular depolarization, what part of our, we have atrial contractions taking place. We don't see it as any movement on our line. And then what gets the signal? Atrioventricular node gets a signal, hangs onto it, blood down. Atrioventricular node gets a signal, relays that signal over to the bundle of His, and sends it on down the ventricle. So it's going towards the positive side. What are we going to see here? It's going to go up, and then we ricochet around, comes back up this way. So we will see it as coming back down here. And then what happens? So this zigzag is called what? QRS. Yeah, QRS complex, and that is ventricular depolarization. Excellent. P is atrial depolarization. Okay, QRS complex. What is happening in the heart in this flat line area after the QRS? Ventricular contraction. And then we have the T, which means what's going on in the heart? Repolarization. Beautiful. Okay. So what I'd like you to know is geographically, anatomically, associate these electrical things. So if I were to say somebody's having a problem with their P wave, what part of the heart would you suspect is giving them trouble? The atrial. Mm-hmm. And if they're having some wonky looking shaped QRS complex, you're looking at it and you're like, I don't know, I just like all the waves are there, but it's all like stretched out and weird. What part of the heart's gonna be having a problem then? Ventricles. It'll be a little more serious because if the ventricles are having a problem, then you really have to get on it. But yeah, so I want you to just associate these things with parts of the heart at the very least. And so this, if you're seeing this, how many heartbeats do we see here? 3. Okay, good. I'm glad you didn't say 9. So, because some people think there's like a weird heart, like a normal, and then weird, normal. So that you know that each one of these is a set for a single heartbeat. So one heartbeat is going to should have all 3 of these waves. So when you're first looking at someone's charts of sort of their EKG charts, you want to look, is it regular? Are these things nicely, evenly spaced? Are all the waves there? Is there any weird gaps? Is there some kind of delay going on? Are there shape changes in these? So that's what you're really looking for. Is there an abnormal size? Is some of them bigger than others? So that's what you want to see, and I want you to be able to label these. You should be able to label a heart with the electrical regions. You know, might say, what's this green area? Like bundle of his, bundle branches. So just label that, and then be able to know on here, what does the P wave mean? Atrial depolarization, QRS, ventricular depolarization, T wave, ventricular repolarization. If you got that, you're 85% of the way there on your EKG stuff. So, I mean, I know it seems really confusing, but I still just kind of want you to know these other elements. A couple questions on, hey, you have a positive wave going towards a positive electrode, you're going to get a positive deflection. So there's a couple more questions kind of there. Then we have some terminology questions. Sinus rhythm. Sinus rhythm is normal rhythm because it's coming from the sinoatrial node. Now, if you're my son, who's like a little hypochondriac, if something has a label like, ooh, my heart rate, you're fine. Am I going to die? You know, because if it must be something bad. So, I know, you're fine. That's just sinus rhythm. I'm not that nerdy. I don't tell my son he has sinus rhythm, but that's what it is. So just because something has a name doesn't mean it's bad. So that was just normal, sinoatrial node, everything's looking good. If someone is bradycardic, they have bradycardia, that just means they have a slower than normal heart rate. Perfectly normal. In some cases, if it's really slow, you might need a pacemaker. But some people have a perfectly normal heart rate sitting there at 40 beats a minute. It's not ideal. Aerobic athletes tend to have really low heart rates that could freak out your doctors, or you can, so bradycardia is not abnormal, can be in some cases. Tachycardic, less desirable. It's just a faster than normal heart rate. Can be on the normal side, but you start inching up a little further away, it starts to add to the concern that why is your heart sort of beating so quickly. So around 70 is what they consider the average. So anything sort of below 60 would be considered bradycardic. Greater than 100 is tachycardic, and that's really not considered to be a positive attribute. You can also have irregular rhythms, and that's obviously not a good thing. A varying RR interval. So I want you to think of R as RQR. Let me go back to this here. And so people go, well, why wouldn't it be the P to P, since we know a heart rate is initiated at the P wave? But because the R is such a prominent electrical peak, a heartbeat is counted from R to R, even though P is the actual start. But it's such a small, insignificant wave, it's hard to pinpoint. And if you imagine back before we had all these like electronic devices where you just see the electrocardiogram, you had, even back when I was in graduate school in the 90s, you could walk through the cafeteria at the hospital and you could spot a cardiologist like a mile away. I mean, because everyone's got stethoscopes around their neck, so that didn't even count. You could spot a cardiologist because he has these calipers in his breast pocket of his lab coat. And the calipers are just, it's almost like a little measuring thing. It's like a little metal thing with a slider on it. And that's when you go to a patient and have paper coming out, like the chart recorders of their EKG, and they'd hold it up and they'd take their caliper and they'd go R to R, and they could say, oh, his heart rate is blah, blah, blah. And so they're actually counting it from the squares on these old chart recorders. And we used to do that as part of our lab, and we don't do it anymore because there's so many electronic devices that do it. Even the electronic devices that we are going to be using today, where we put our fingers on these electrodes and you're going to see your own electrocardiogram, is when it just gives you an instant readout of your heart rate 72 or whatever it is. The instant readout is measuring the peak electrical surge to the next peak electrical surge. You would have one that you'd go, here's a P, QRST, you have P, QRST, and then you have a gap, P, QRST, you can see, but like this would be normal, and then all of a sudden there's a delay, and then it's kind of normal, so that's kind of varying. And then it could speed up, slow, you might get some that are really crunched together, some are long. So if your heart's sort of doing this, where it elongates the distance between, and then you may not notice that without looking at this. If you're just doing a monitor thing, it's sort of averaging over time. Oh, there's 72. Well, if your 72 beats a minute includes a whole bunch of these scrunched together and a few of these farther out, 72 is still fine, but it's not really, there's not a lot of good things going on. You know, something's wrong with the pacing. So those are some of the just terminologies you'll need to know. This you don't need to know for the test. I'm just going to relay this to you because many of you guys are going to be seeing some of these as you do different work. So there could be conduction problems, meaning how's the signal getting through the heart? There's an atrioventricular block. We actually have first, second, and third degree blocks. And a block would mean maybe the signal's not always getting through. You might have your normal P, QRST, PQRST. It's kind of wonky. Okay, so what do we see here? You know, obviously my bad drawings, there's that, but so we see an extra wave over here. Perfect, exactly. So what we have, so I tried to draw normal, normal, but uh-oh, bigger gap going on here. Uh-oh, another uh-oh. Bigger gap happening. Okay, we're back to a normal beat. Oh, we just have this. This would be a P wave that was completely blocked, never made it to the ventricles. And then the next beat, okay, it finally did it. So it's like almost intermittent where the atrioventricular node is like, maybe I'll let it through, maybe I won't. And that would be a conduction problem. Fibrillation just means you're going to see it as lots of wiggles. And if they're little wiggles, in the atria. If it's bigger wiggles, you're in really big. It's bigger, it's more heart mass. That's when you see somebody with that, that's when they go get the shocking probes. And then you want to shock them because what happens is if you shock a person, you massively depolarize their heart. Everything's depolarized. You want it to all repolarize, and then there's that moment where it's like nothing, and then you're silently in your mind rooting for the sinoatrial node. Come on, SA node, come on, depolarize so that you can initiate the beat before these really weird, unstable ventricular cells decide to initiate it themselves. And so if you can get that beat initiated by the sinoatrial node and follow the right pattern, everything will fall back in sync. Otherwise, each little part of the heart is just doing its own, and you're not going to collectively send blood out. So that would be fibrillation. What we have here, I'm going to draw again, depolarizing in red. What was depolarization due to? What ion was it going? So let's just say I sort of do this this is my shorthand. Sodium into the cell, okay? And it's making the cell more positive. You hit your plus 30, then the sodium channels are closed. And then, actually maybe we'll draw on a little picture here. Depolarization. Sodium going into the cell, making the cell more positive. At plus 30, what happens after our sodium channels are closed? Potassium's going to go. So that would be our blue over here. So we're going to talk about the purple in a second. So all of a sudden we have potassium starting to come in or come out. So we'll draw that on our cell. So if we have a cell here, and we already have our sodium channels blocked. That's why I put a little X there. So no more sodium's coming in. But at this point, we are allowing potassium to leave. So if the plus is leaving, we would expect it to. But the heart says, you know what? We don't want to have a fast action potential. We want to drag this thing out. So not only do we have potassium starting to go, but then the heart does this extra thing that the nerve doesn't do. It lets calcium into the cell. So we have a plus leaving and we have a plus going in. So the two opposing each other means that we're really net neutral. We're not going one place more than the other. We have, so both of them are working, but they're opposing each other. And then finally, over in this second scenario, so this is what we call the plateau. And, oh, dang. Okay. I heard a little chime. I'm like, oh, I was hoping, I'm so mad at this. I don't want to get a new one because I'm waiting for the next ones to have more USB connections, and they're supposed to get another, like, what are the C connections? I'm like, I'm not buying a new one yet. But it's got the batteries down to nothing, and I hate having that cord here. So I was hoping I could charge it through the first class and then not have to have it charged for yours. So that was a fail. So, okay, so calcium is on a timer. So after a while, calcium gives up and potassium sort of wins the day, and potassium continues and will actually do its repolarization. So the next slide I had for you was showing you a super skinny nerve one and then the longer, wider action potential for the heart. Who can tell me why we would even want the action potential for the heart to be so wide and so big? What purpose? We want it to fill with blood. Yep. To fill with blood. Okay. So if we were to say take our bicep, and I got my hefty dumbbell here. So if I go, little nerve goes down, tells the bicep, twitch, like that. But if I just want to hold this thing, and I'm really, you know, just nice and steady, I'm going to be sending a nerve down, and I'm going to be doing what's known as tetanus, maybe not maximally contracting, but where I'm stimulating this muscle repeatedly so it never relaxes, or at least for this duration. Do we ever want our heart to do that? We never, ever want our heart to go, okay, let's just hold on to this for a while. You know, we want our heart to be able to squeeze and relax so it fills up with more blood, and then squeeze again to send it out, and then relax. So if we were to all of a sudden be really scared and our nerves are telling our heart beat faster, we never want it to beat so fast that it stays contracted. So by having this duration, and therefore sodium channels are locked for longer, we actually force the muscle an opportunity to contract and actually start its relaxation before we can actually come down and get another beat in. So this is a safety mechanism for the heart to prevent contraction of just a steady contraction. That's all. Okay, so don't have to worry about that. So what you will need to know from this section, and I'm just trying to think of test questions from here, and what I want you to know and understand is a lot of it will be review from 201. Tell me the ion involved in depolarization. That would be sodium. Which are the ones involved in the plateau? Calcium influx and potassium efflux. What ion is involved in repolarization? And that would be the potassium. So 2 of those 3 questions we already did in 201. Sodium is depolarization, potassium is repolarization. We just prolong the repolarization by throwing in calcium. So we let calcium in for a while. And that is pretty much it. Oh, except for, sorry, I probably like to put voltages in there. So if we have this here at plus 30 millivolts, that's where all of this. Plus 30 is when our sodium is going to shut down, and that plus 30 is the signal to tell potassium channels to open, as well as tell calcium channels to open. So that's all. Where it was like the minus 55 is what told the sodium to open. And sometimes I have some, usually questions will have some reference so that you know at least some voltage. And then I have also on your notes a list of the sodium significance. So it's really meant to remind you that it's here part of depolarization, and it kind of goes through these again, but just in a more wordy format. Then I have a slide that has the classification of drugs. You don't need to know that. That is intended to be in there. So I have many students that once they go to nursing school, when they're doing their pharmacology, they get way more detail. So it's not just down to one slide, but it gets you to see what class 1 drug's going to do versus the class 2. And you can actually take, if someone's got cardiac electrical problems, you can see where, say, taking lidocaine, which is a sodium channel blocker. If you're going to block sodium channels, how is that going to affect your heart rate? It's going to lower it. If you're going to block sodium channels, it's harder to depolarize. What if you are going to help open potassium channels? What are you going to do? You're going to repolarize more quickly, therefore you can have the heart rate more quickly.